So hello everyone, today I'll continue my discussion on keratitis and today I'll be talking to you about infectious, non-purulent or non-suppurative keratitis. So in my last class I already discussed about the purulent types of keratitis. So in today's class mainly infectious, non-purulent or non-suppurative keratitis, and the organisms which cause them are viruses and parasites. Okay, and in parasites we have protozoa and helminths. Okay, helminths. In protozoa I will mainly be talking to you about Acanthamoeba, and in helminths I will be talking to you about Onchocerciasis. Okay. So let me start with viruses. So viruses which cause ocular infections have mainly affinity to epithelium. So they will affect the epithelium of the conjunctiva and cornea and will cause different forms of keratoconjunctivitis. Okay. So I'll be mainly talking to you about Herpes simplex virus and Herpes zoster virus. Okay. Today in my discussion, because these are the most important MCQs also and these are the most important clinical forms also. Okay, so I'll start with Herpes simplex virus. So Herpes simplex virus is actually a DNA virus. Okay, this is also an MCQ. Immunologically, this virus is of two types, type 1 and type 2. Okay, so type 1 is different because it causes infections above waist, okay, above waist, and type 2 will cause infections below waist. Okay, but this type 2 can also cause ocular lesions, and the most important form of it is ophthalmia neonatorum. Okay, so this is the conjunctivitis which is acquired by the neonate during birth because of the infected genital of the mother. Okay, so ophthalmia neonatorum. This also is a question. Okay, so herpes simplex 2 virus. So now this herpes simplex type 1 virus mainly will cause two types of keratitis, okay, or ocular infection. So the first one will be primary. Primary means when the infection is contracted by the patient for the first time. So in primary, it can be from 6 months to 5 years of age. Okay, and it will be in form of a follicular conjunctivitis. Okay, and the keratitis which occurs in this case will either be punctate, or means it is in form of dots. It can be a localized form or it can be a diffuse involvement of the entire cornea, or it can be in form of a ulcer which is dendritic. Okay, so it will have branching. Okay, so this is a epithelial ulcer which is caused by herpes simplex 1 virus during its primary infection. Okay, now this episode will resolve, and later in life, sometimes because of the immunocompromised state of the body, or because of some illness, or because of diseases like malaria, or sometimes due to menstrual stress itself, this virus is again activated and now it will cause a recurrent form of disease. Okay, now this is called recurrent. Okay, so recurrent form of keratitis can again be in the form of punctate once. It can be a dendritic ulcer. Okay, so what is a dendritic ulcer? So again, my dendritic ulcer which is there, it is a branching sort of an ulcer. Okay, and this branches will have terminal bulbs. Okay, and this is very pathognomic of herpes simplex, and that is why it is called a dendritic ulcer, and this thing is called a dendrite. Okay, another important MCQ about this is that this dendritic ulcer, the margin of the ulcer will be staining with rose bengal. Okay, so I'll just write down here. The margin of the ulcer will be staining with rose bengal. Okay, this is a stain, and the base of the ulcer, however, will be staining with fluorescent. Okay, So sodium fluorescent. So the margin of the ulcer, when you stain it with rose bengal, it will look red pink sort of, and the fluorescent will look green. Okay, so this is very pathognomic of a herpes simplex lesion. Okay, another thing which it can cause is also called a geographic ulcer. Okay, so what is this geographic ulcer? These dendrites themselves, they can fuse together to form a larger ulcer in form of an amoeboid configuration or like a map. That is why it is called a geographic ulcer. Okay, so this is also a question, geographic ulcer. So these are the various forms of keratitis. Epithelial keratitis, which can be caused by herpes simplex type 1. Okay. Now, not just epithelium, sometimes stroma also might be involved. But the peculiar thing about this stromal keratitis is that it is not due to direct viral invasion. Okay, so this stromal keratitis is not because of direct viral infection. This is actually due to a delayed hypersensitivity reaction. Okay, so this is a delayed hypersensitivity reaction. Okay, that will occur. So how will it manifest? So suppose this is the epithelium. Sometimes the epithelium is not involved. Okay, and sometimes the epithelium might also be involved. Okay, so there will be an epithelial defect sometimes, or sometimes there might not be an epithelial defect, but the stroma which is there, it will have opacities. Okay, and edema. So stroma will have edema, but epithelium might be intact or it might be eroded also in case of stromal keratitis, right? No, so this is one kind of stromal keratitis, okay, which is called disciform keratitis. Now sometimes what might happen, it can be a diffuse type of keratitis. So it's called diffuse stromal necrotic keratitis. Okay. So when there is a diffuse stromal necrotic keratitis, what will be the picture? Suppose if this is my cornea, the stroma will have cheese-like, okay, cheese-like opacities because of the necrosis, and there will be a diffuse involvement. The prognosis in this case is very bad. Alright. So these are the different types of keratitis which can be caused by herpes simplex. Now I'll come to the treatment of how do we treat these types of keratitis. Okay. So the diagnosis is usually clinical. Okay. In this case, and coming to the treatment of these forms of keratitis. So I told you there are two types of keratitis. There is epithelial keratitis and there is stromal keratitis. So coming to the epithelial form of keratitis, so how will you treat? Because the infection is active, so you have to give antivirals to the patient. Okay, the antivirals have to be topical. So what will you give? You can give acyclovir. Okay, this is the least toxic and the most effective drug. 3% acyclovir. You have to give acyclovir 3% 5 times to the patient till the ulcer heals, and then you can taper it down to maybe 3 times depending upon the response of the patient. So this acyclovir you can give ganciclovir. Okay, this ganciclovir is present as 0.15% preparation. You can give another drug which is called vidarabine. Okay, and you can also give trifluorothiamidine. Okay. So these are the antiviral drugs which can be given to these patients. Of course, the general line of management will be same. Again, you have to give analgesics, you have to give cycloplegics to the patient. The rest, the diet will be all the same. And also this condition is very infective. Okay. So it spreads from one person to another. So the spread should be taken care of by maintaining hygiene. So this is the epithelial form. Okay. But when it's a stromal form of keratitis, as I told you people, that it's a delayed hypersensitivity reaction. So to reduce that, you must give steroids. Okay. So a low dose steroid must be given. Okay. Steroid. But also you have to maintain an antiviral cover. Okay. So antivirals need to be given along with low dose steroids to treat this stromal form of keratitis. So as I told you, there are two forms of stromal keratitis. One is disciform So disciform keratitis will have a good prognosis when you give this treatment. But when you have a diffuse necrotic type 1, that time this is not going to respond very well to this because of the widespread necrosis, and in most of the cases you have to do a keratoplasty. Okay. Okay, you must remember that herpes simplex virus keratitis is a very common cause of failure of keratoplasty, because most of the times whenever you give a new cornea to the patient, the virus will again infect the cornea. There will be a recurrent form of disease, so it's a very important cause of failure of keratitis also, this herpes simplex virus keratitis. Okay. Now, from herpes simplex virus keratitis, I'll move on to herpes zoster ophthalmicus. Okay. Herpes zoster ophthalmicus also. So it's caused by herpes zoster virus. This HZO basically is an infection of the Gasserian ganglion. Okay, Gasserian ganglion. This is a ganglion of the fifth nerve. Okay, the Gasserian ganglion is a ganglion of the fifth nerve. Okay, now this herpes zoster ophthalmicus is actually this virus causes chickenpox also, and this virus causes HZO also. Okay, so in childhood this chickenpox is contracted by most of us, and then the virus will become latent in the ganglia, okay, the neural ganglia of the patient. And again, this because in elderly patients in immunocompromised states, this herpes zoster virus will again become activated, and this might cause herpes zoster ophthalmicus. And one very important thing to note down is that clinically, when you see a young patient who has this herpes zoster ophthalmicus, you must work up the patient for HIV. Okay, so you must never miss working up the patient for HIV when you see herpes zoster ophthalmicus in a very young patient. Okay, because this is mostly a disease of elderly people in immunocompromised states. Okay, now how will this herpes zoster ophthalmicus manifest? So there are some general features as in the systemic features. So first there will be fever, malaise, pain. Okay, and why I am telling you all this, that this pain is very characteristic because this pain has dermatomal distribution. This pain is so typical that even before the skin lesions develop, you can actually diagnose the herpes zoster ophthalmicus depending upon the dermatomal distribution of pain. Okay, so one thing, after 3 to 4 days after this, the skin lesions will develop. Okay, skin lesions. So strictly unilateral lesions. Okay, so only one side of the body, upper half of the body is going to be involved, which will give you a very very typical peculiar kind of a diagnosis of a herpes zoster ophthalmicus. Okay, so skin lesions will be unilateral. They will be in form of vesicles. Okay, then they will form pustules, and finally they will form scar tissue. And this scar will not heal, so they'll have this scar will be in form of a permanent scarring. Okay, what is also very peculiar about this herpes zoster ophthalmicus is that it gives rise to something which is called post-herpetic neuralgia. Okay, so what happens, even when the skin lesions and everything is healed, this pain of the patient might stay. Okay, and it reduces very less in intensity to the first encounter which the patient has had with the virus. So a very severe pain might stay even after the cure of this kind of infection, which is called post-herpetic neuralgia. Okay, and this might also lead, it might be so severe that it also might lead to depression and suicide. So suicide can be committed by the patients who have this post-herpetic kind of neuralgia. Another thing which is caused by this virus is also called anesthesia dolorosa. So what is this anesthesia dolorosa? So when this post-herpetic neuralgia is accompanied by analgesia of the involved part of the skin, this is called anesthesia dolorosa. Okay, so both these are questions: post-herpetic neuralgia and anesthesia dolorosa. Okay, now I'll come to the keratitis part of it. So what can be the ocular features of it? So ocular features, again, it will be an acute follicular form of conjunctivitis. Okay, and There will be lymphadenopathy along with that. Most of the viruses, when they cause conjunctivitis, you must look for lymphadenopathy also, which helps you in making a diagnosis of the etiology of the conjunctivitis. So conjunctivitis will be there, and keratitis, again this might be in form of punctate keratitis. Okay, so dots might be there, punctate keratitis. Another, this will cause something which is called a microdendritic ulcer. So what is a microdendritic ulcer? We already talked about dendritic form of ulcer. So this form of ulcer, they will be peripheral. Okay, so they will be peripheral and they will be more stellate or star shaped, and they will not have any terminal buds. Okay, so because of the absence of these terminal buds, because of their peripheral nature and their stellate forms, these are called pseudodendrites. Okay, so this kind of clinical presentation will help you to distinguish between a herpes simplex or a herpes zoster type of keratitis. Okay, so this microdendritic ulcer. Okay, again you might also have stromal keratitis. So another thing which will be your nummular keratitis. So what happens in this nummular keratitis? There will be tiny granular deposits in the stroma, and they will be surrounded by a stromal haze. Okay, stromal haze. So this is nummular keratitis. Then will be your disciform keratitis. Okay, in the same way, disciform keratitis, there will be stromal edema because of the confluent nature of this nummular keratitis. You can also have neuroparalytic keratitis. Okay, because of the destruction of the Caesarean ganglion altogether. Okay, and then you might have something which is called mucus plaque keratitis. Okay, so now the cornea will have lesions which are elevated. Okay, that is why this is called a mucus plaque keratitis, and these plaques will stain very brilliantly with rose bengal. Okay, so these are the different types of keratitis which can happen in case of a herpes zoster ophthalmicus. Other than this, there can be more ophthalmic features of this herpes zoster ophthalmicus. Might have iridocyclitis in these patients. Okay, there might be nerve palsies in these patients, and there can be acute necrosis of the retina. Complete retina will be necrotic. There will be optic neuritis, and sometimes the entire anterior segment will get ischemic and the eye will go into phthisis bulbi. So these are the different types of ocular manifestations which occur in herpes zoster ophthalmicus. Okay, so how do you treat this condition? So when a patient comes to you, you're going to give a cyclovir systemic. 800 milligram of tablet is given 5 times a day for a period of 10 days. Okay, and one very important thing of this is that this should not be started later than 72 hours. 72 hours is the time when you should start this acyclovir for it to be most effective, and that is when the patients might have a better prognosis. Okay, so you must start acyclovir within 72 hours. Other things you can do for this patient will be analgesia. Okay, so antidepressants can be given because of this severe kind of pain of post-herpetic neuralgia. Of course, general lines of management is again same. You have to give cycloplegics to the patient. You have to give dark glucose to the patient. So all those things, where in the general form of for the treatment of bacterial ulcer or fungal ulcer, they all will apply to your herpes zoster ophthalmicus keratitis also. Okay. So these are the things which you need to do. So I'll tell you some 2-3 important MCQs about this. So the first MCQ is that the most So the most common nerve which is involved in this palsy is third nerve. Okay, third nerve or oculomotor. Okay, so as a complication when the nerve palsies develop, the first nerve to be involved is your third nerve. Okay. Now another thing which is also important is your Hutchinson sign. Okay, so what is this Hutchinson sign? Okay, so what happens? When the tip of the nose is involved or when the ala of the nose of one side is involved, it is most likely that an ophthalmic feature will also be present. This is because the nasociliary nerve has the same supply for the tip of the nose and the ala of the nose and the iris. So, nasociliary nerve is the nerve which is involved, and the most common nerve to be involved by Herpes zoster ophthalmicus is the largest branch of the ophthalmic nerve, which is the frontal nerve. Okay, so the frontal nerve is the most commonly involved branch of the ophthalmic division of the trigeminal. So these are the three questions which you must remember. Okay, sometimes you might also get an MCQ that which is the least common nerve. Okay, which is involved in palsy. So the answer to that is seventh nerve. Okay, so this is the most common and this is the least common. Okay, so this is all about Herpes zoster ophthalmicus. Now, after we finish the viruses, I'll move on to parasites. So first I'll talk to you about Acanthamoeba. Okay, this Acanthamoeba also is a very peculiar organism. Okay, Acanthamoeba. This exists in two forms. Okay, there are active tropozoite forms and there are dormant cysts. So whenever conditions are not favorable, this Acanthamoeba will change into cysts. Okay, so what is the mode of transmission? How does this infect our cornea? Mainly in contact lens patients and the patients which swimming pool. Okay, when the patients go into a swimming pool or contaminated waters, they take bath, they will have this Acanthamoeba kind of keratitis. Okay, another peculiar feature about this is that the pain in this Acanthamoeba keratitis is very, very severe in comparison to signs. So this is a very painful form of keratitis. Okay, and you must suspect Acanthamoeba kind of type of keratitis when a patient who's wearing contact lenses comes to you. This is very notorious in mimicking other types of infections. So most of the time you will diagnose it as herpes simplex keratitis and you will start treating in the lines of herpes simplex when later you find out that it's actually an Acanthamoeba type of keratitis. Okay. So what is the kind of clinical manifestation or what is the kind of keratitis it will have? So first, it will have epithelial and subepithelial opacities. Okay, and MCQ peculiar thing which it causes is radial keratoneuritis. Okay, so what is this radial keratoneuritis? So this has the tendency to infiltrate along the corneal nerves. So that is why it is called radial keratoneuritis. And when this form becomes advanced, it leads to formation of ring corneal infiltrate or abscess. Okay. So this is the manifestation of Acanthamoeba form of keratitis. So how do you treat? So treatment, again the same way we treat most of the keratitis. The specific treatment to this Acanthamoeba is the drugs which act against this Acanthamoeba. So what are those drugs? The first one is biguanides. Okay. One example is PHMB. Okay. So you have to give this biguanide. This biguanide is a good drug because it acts against tropozoites also and cysts also. So this is one question. So this is the only drug which is used in treatment of Acanthamoeba which will be acting against both tropozoites as well as cysts. Another drug which we use is propafenone. amidine, okay, 0.1%. This is another drug which is used. So this will only be acting against leukocytes, this will not be acting against cysts. Third drug will be neomycin, and you can also use antifungals like itraconazole and miconazole. Okay. This Acanthamoeba keratitis takes very long to heal, so you have to give a prolonged treatment in case of Acanthamoeba, which might be as long as 6 months also, to treat this Acanthamoeba kind of keratitis. Okay. Okay, I forgot to tell you about the diagnosis of this Acanthamoeba keratitis. These are also MCQs. So what are the diagnostic features? So when you want to do a culture, you will use non-nutrient agar which is enriched with E. coli. Okay. Rather dead E. coli. So why? Because Acanthamoeba will feed on this E. coli. So that is why you have to use this for the culture, non-nutrient agar which is enriched with E. coli. Another thing, you have to use 10% KOH for these patients, and calcofluor white stain also is used in case of Acanthamoeba. So these are the two stains which are also used in case of Acanthamoeba. Okay, this is the diagnostic modality. Now lastly, I'll talk to you about Onchocerciasis. Okay, so a few points about Onchocerciasis. This is also called river blindness. Okay, one MCQ. This is the second most common cause of infectious blindness. Okay. So you'll ask me what is the first common cause? So the first most common cause is, of course, my trachoma. Okay. Okay. Another peculiar feature of this Onchocerciasis is that it is very common, or it is endemic in Africa. Okay, the savanna regions. So if you get an MCQ, if you have a patient is of African origin, you must think of Onchocerciasis. Okay. Now, what is the causative organism of it? So it's a helminth, and that is Onchocerca volvulus. Okay. So this is the causative organism. What is the vector? So it is Simulus blackfly, which is the vector in this Onchocerciasis. And another very peculiar thing about this is that in this Onchocercia, in the adult as well as the microfilaria forms, there is a rickettsia which is called Wolbachia. Okay, this is also a question. So this Wolbachia is present inside this Onchocerca, and it helps in the growth of microfilaria. Okay, so that is why when you are going to treat this Onchocerciasis, you might also attack on Wolbachia, and that will help to eradicate the infection of Onchocerciasis. So what is the clinical manifestation of this Onchocerciasis? How will it present? So it involves skin. So in skin, it will have maculopapular rash. Okay, this is also called leopard skin appearance, which will happen in case of Onchocerciasis, and it will form onchoceromas. Okay. Coming to eye, it will cause keratitis. Okay, and this keratitis will be in form of snowflakes. Okay, so this is also an MCQ. Snowflake keratitis happens in case of Onchocerciasis. Okay, it will cause iridocyclitis, and sometimes these live microfilaria can be seen in anterior chamber, sometimes they can be seen in vitreous and retina. So these are the clinical manifestations of onchocerciasis. Repeated infections from this onchocerciasis will lead to decreased immunity of the individuals who have this infection. Okay. So what is the treatment for this onchocerciasis? One drug is ivermectin. Okay. So in the countries where this is endemic, this ivermectin drug is given free of supply to the patients. But this drug is not very effective, so a newer drug is moxidectin. Okay. This is a better, newer drug. I told you that you can also attack on Wolbachia. So the drug which acts on Wolbachia is doxycycline. Okay, so doxycycline. And one last drug is suramin. Okay, so the suramin has to be given intravenously. Okay, so these are the drugs which are going to act: ivermectin, moxidectin, doxycycline, and suramin. Okay. So before I close this topic on infectious keratitis, I will tell you about a miscellaneous form of keratitis, which is infectious crystalline keratitis, or ICK. So what is this ICK? The word infectious, this is infectious of course, but it is non-inflammatory. Okay, so this is non-inflammatory. The word crystalline, why crystalline? Because it gives rise to crystalline arboriform deposits. That is why it is called infectious crystalline keratitis. Deposits in the stroma. That is why keratitis. So ICK, infectious crystalline keratitis. So which are the patients who are going to have this ICK? Immunocompromised individuals. Okay? Immunocompromised. The patients who are using steroids for a very long time, those are the corneas which will be predisposed to this infectious crystalline keratitis. And what happens is, the periocular pathogens only will come along the suture tracts in patients who have had keratoplasty and will come and harbor this infection. Okay? So how do you treat this ICK? So treatment is very tricky because it usually does not respond very well, and because of the recurrence and because of the scarring, you anyway have to go for a keratoplasty, but still a trial can be given by broad spectrum antibiotics for a very long time, okay, depending upon the response, and you have to reduce the duration of frequency of steroids. Okay, and that is how you will be able to treat this ICK. So hereby I come to an end of infectious keratitis. I will be talking about keratoplasty in my next class before I move on to the non-infectious forms of keratitis. Thank you so much for your patience.